the presentation I gave yesterday on mLIPI was looking at, could we identify or have a system for identifying in the clinic, with patients sitting opposite you, who's most likely to benefit from therapy. So we looked at a number of factors. The first factor was how fit the person is, called performance status. The second factor we looked at was the neutrophil lymphocyte ratio. Now, in cancer, lymphocytes are often, the level of lymphocytes is often a bit reduced, and the level of neutrophils may even be a little bit elevated. So looking at the ratio may help to identify patients who are going to do better or worse. And then the third thing we looked at was LDH. Okay, and that's well known to be a biomarker that might be predictive of the tumour burden and how well somebody is likely to do with treatment anyway. So we combine these things together. And so we got a scoring system of 0, 1, 2 and 3. And we were able to see that based on the score that you got, your chances of benefiting from treatment with Nivolumab in particular in the second line setting, but we think it also applies to all of the others, all of the other immune therapies that are coming through, we could really tell who is likely to get the most benefit. Okay, and so that would help you and help to inform you. One, should I be treating the patient, and other things I need to look at in these patients to see should I treat them or not. And there probably are. So if you had a very frail patient who comes in and has got a score of 3, you'd say, well, maybe what's the benefit going to be here? If you've got somebody maybe who is very mentally alert, otherwise, seems tuned in, but it's all symptom related, you might say, related to the cancer, you might say, well, maybe I'll treat those patients. So it's a bit of a hard one, but you can at least begin to think about what you might do. So the question was asked, would PD-L1 staining and tumour mutation burden add to that? And the answer is probably yes. So if you get somebody who's got a very high PD-L1 level in their tumour, or who's got a high tumour mutation burden, you've done the assay for it, then obviously that then may swing you in favour of treating somebody who might not be so fit. So I think those things are really becoming very important now. So they're helpful in the clinic.